Welcome to Trace Neuroanalytics, episode 2. My name is Nikki, and today we're going to be analyzing an EEG. Thank you to James Kroll from Bay Area Peak Performance for submitting this data. I've not seen this data yet, and we do have some clinical info, and we're just going to take a look at what's going on. If this is your first time here, just a reminder that this is a non-medical interpretation, and hopefully will be interesting to open some doors and deepen our understanding of what's happening in this brain. So without further ado, we're going to begin the EEG analysis. We're going to start with the eyes open data. This is 19-channel EEG. I've undone any of the ICA analysis, and I'm also going to clear all of the artifacts that have been marked here. And we're just going to start scrolling through and seeing what story this brain has to tell us. Quick reminder before we get started, if you are interested in a fun video like this yourself, traceneuro.co is the place to go. And you can subscribe to my YouTube channel at eegworld.com. Thanks for watching. So we'll start scrolling through the data. We have eye blink here at the front of the head, as well as some muscle tension that's showing up, not throwing up. On the right side over here at T8, common place for muscle tension to appear. And we see some alpha activity at the back of the head. It's starting to peek through here. Right now we're at 50 microvolts scale, so relatively normal EEG in terms of power. And we're starting to see some right and left temporal theta activity, slower activity here. More eye blink and a good run of frontal theta here at FC, frontal midline theta. This is 1, 2, 3, 4, 5 hertz-ish. So frontal midline theta is a normal EEG feature, and we'll be watching out for how often that pops up. And we see a little reduction in the background power here. So it's starting to look like we're going through different states or different phases of vigilance, right? In the European model, they only look at vigilance in the eyes closed. But when someone is sleep deprived enough, we can see changes in vigilance even in the eyes open. And we have some evidence that that is happening here because of the prevalence of this theta, followed by a pretty significant reduction in the background power here, only 25 seconds in. So we're starting to identify some recurring features, more frontal theta, some of this alpha activity at the back of the head when the eye blink happens. We'll plan on eliminating the eye blink artifact using ICA a little later, as well as this muscle tension in the right mid-temporal region. Interesting to see how predictably the alpha rhythm at the back of the head emerges after eye blink, and also how it sort of generalizes to the entire head after the eye blink, right? So that's another sign that there might be some drowsing. Usually alpha starts at the back of the head, and as there's more drowsiness, it goes to the front. And this is starting to get more interesting. This is sort of unclear here because this could be eye movement, eyelid flutter, rather, given that this is what an eye blink looks like. However, I'm inclined to think that this is more likely actual genuine frontal slowing because the topography is much more biased towards FC as opposed to just really being focused around FP1 and FP2. And here it's a little more clearly differentiable because we have eye blink or eyelid flutter that's clearly happening here, and really more classic and obvious frontal midline theta here at FZ. And the alpha activity is increasing in the back of the head, but there's also real theta mixed in, right? Here's P7, the site behind the left ear, showing basically the same theta activity. So there are issues here in regulating vigilance because we're going from this sort of global slowing, eye blinks, and then to sort of a dropout of the background rhythm with more eye blinks. So it seems like this person kind of struggles to stay awake, and certainly the frontal midline theta in this amount, here we see it again after another eye blink, is something that would potentially impact the metabolic capacity of the anterior cingulate. Here we see an alpha resurgence after eye blink, really going through quite a few different states, shifting between this alpha dominance, the theta dominance, and then sort of a dropout of the background power. And look at how much smaller in amplitude this is than what we were just looking at. So even though the eyes are open, we're getting into sort of stage B sleep. More eye blinks. Same sort of low amplitude background activity. And a brief alpha resurgence accompanied by some frontal beta, which is interesting. Eye blink followed by frontal theta. And a pretty significant dropout again. So real difficulty in maintaining state of vigilance here. Muscle tension. Return of the alpha. It looks like it's about 10 hertz here. Some lateral eye movement. More lateral eye movement. And we're just scanning for any focal findings. So far, nothing has really jumped out as something that would be locally worrisome. More frontal eyelid flutter. Look at this alpha burst here. Low amplitude and actually generalized. And this is a little bit faster than the alpha that we saw before. That was around 12 hertz. So we could also be witnessing some state instability as far as the alpha tuning, right? If the alpha wanders around with changes in vigilance, that can indicate some issues in terms of maintaining the same level of activation. It's a little bit hard to see what's going on with all the eye movement, both eye blink and lateral eye movement. That can be a sign of different things. It's not necessarily a bad sign, but sometimes when we see lots of eye movement, it can be associated with hypervigilance. Interesting feature here. Right here at 390, we see this kind of sharp wave that is phase inverted front to back. And we can see that this is not coming from the eyes because this eye blink right here we see has much less of an impact on the rest of the topography, whereas this really seems to be coming from kind of the middle of the brain and projecting forwards and backwards. Followed by a run of theta and then a dropout. So that looks like some kind of an instability. Muscle twitch. Lots of eye blink. This can be associated with trying to stay awake. Frontal theta. Again, the little bursts of alpha with the eye closures. Lateral eye movement. Muscle tension. Lots of lateral eye movement. Kind of a dropout in the background power. And again, we're starting to see some little beta spindles here. Lateral eye movements, eye blinks, posterior alpha, muscle tension, frontal theta. And we're at the end of the file. Great 10-minute recording. And let's conduct the ICA artifact removal. I'm going to left click at the beginning of the record, click on Mark Artifact, turn off the PCA denoising because we have a nice fast single thread computer here. And the first component often will be the eye blink component. And we're just going to scroll through to verify that we're not removing any genuine EEG activity, especially given how much clinically relevant frontal midline theta there is. And we've jumped to a good portion of the EEG for that because this is where there was some of that happening. And unsurprisingly, this topography, if we remove it, will be removing some of that activity. So what I'm going to do now is, because I would rather not remove that frontal midline theta quite so much, even though we're really only removing it from the FP1 and FP2 sites, I'm going to switch over to the TON algorithm and keep it on the same epoch. And we'll see if the TON algorithm does a better job. And the short answer is no. However, I'm okay with taking this out because the frontal midline theta is really quite visible on its own when it is happening. And it's more useful for us to get it out. And I'm actually going to scroll back to that same fragment if I can, because that's also a good area to assess how good the lateral eye movement component is. Yeah, we might not be able to find that particular one. So we notice a lot more lateral eye movement later on in the record, and we can see that this component is doing a pretty good job of pulling that out and not squashing the rest of the EEG in the lateral frontal sites, F7 and F8. So whenever I do ICA, I like to remove as little as possible while still getting rid of anything that is non-cortical. And the last thing I really want to try to get out is just this T8 muscle activity. That may be all we need to remove in order to be done here, because the instances of muscle tension that we saw were quite isolated, and I'm not super confident that we're going to get great topographies for them. So I think we're basically done with the ICA. And now I'm just going to manually snip out the sections where there's artifact remaining. So hope this doesn't make you too dizzy. I'm just scrolling through quickly to eliminate the few moments when there is broadband muscle tension. And we can see this didn't fully remove eye blink, but that's okay because it did a pretty good job. Just taking these fragments out so that the spectra are not contaminated by EMG any more than they absolutely need to. It looks like we didn't get quite all of the EMG out of FP2. It's okay. And this looks like this is basically clean. So I'm going to save the file, and now we can start honing in on some of those interesting features that we saw the first time we scrolled through. So here we have a nice little snippet of the frontal midline theta. So I'm going to put that in to our eyes open raw data. And we'll keep scrolling through to find some other features. It's kind of interesting because we see alpha re-alerting. And we're trying to capture this pattern that we've seen of alpha re-alerting and then alpha dropouts and interspliced with these runs of frontal midline theta. And here's an example where that theta is starting to look a little sharper. So I think this is an interesting fragment to pull out. Here's an example of an alpha squeak followed by a dropout of the background rhythm. Another alpha squeak here. This one almost would have been better to screenshot, but it's the same pattern. We'll catch another one. This one's interesting here because it's alpha followed by slowing of the alpha and then this kind of dropout. Since it's the same pattern that tends to repeat itself, we'll keep scrolling, try to find a juicier one, if you will. Global alpha content. And of course, looking for a juicier one is a form of bias, of course. But we are trying to find the most striking features of the EEG in what is essentially, for the most part, just a drowsy EEG. Here's an instance of what looks like something of a sharp wave from front to back. And whether that is clinically significant is hard to tell. Whenever there's something that's sharp, I think it should catch our eyes, both literally and in terms of potential screening for other instabilities. And here's another example of this kind of sharp activity that's phase inverted from front to back. And we've gotten quite a few little snippets, little fragments so far. It'd be interesting to find another one that has that beta spindle in it. And I believe that was earlier on. We may have just run past it. Okay, well, if we don't, we don't. And it didn't happen all that frequently. And we wouldn't be surprised to see beta spindles when there's this much difficulty in vigilance regulation. Let's grab this last alpha squeak. And now we can compute the spectra, the quantitative EEG, if you will. We're going to also compute coherence. Click OK. Fill by band ranges. And what do we see? Right? So whenever we look at the spectral analysis, we always want to make sure we're not making anything up, because the FFT runs according to rules that the EEG doesn't exactly follow. So what's interesting to me is that up front we see two distinct peaks, which we noted in the raw EEG. Right? We saw the brain was sort of wandering around in terms of the peak frequency that I was looking for. As far as what this delta content means at the back of the head, I'm not quite sure, because we didn't really note it when we were looking at the raw, but you can see it back here. Is it an issue? I don't know. Right? So this type of thing is probably lambda activity, which will kind of throw off the FFT since it's non-sinusoidal. And if anything, I'm struck by just how much alpha there is up front because of the drowsing, essentially, and the poor alpha tuning. So that's also a sign of vigilance regulation issues, potentially, even if at the back of the head it's okay. Let's take a look at the spectra that we have generated. And, the main thing that we're seeing is this frontal midline theta, which is very strong, and this kind of diffuse alpha peak, one being at 9.5 and the other one being at 11. So let's insert this into the report. In WinEEG, I find that whenever I click that print preview button, it will take a second to load up the image, and just use this opportunity to remind you that if you're interested in a report like this, if you want to learn more about an EEG that you've already recorded, visit traceneuro.co. And if you're interested in checking out my YouTube channel, that's at eegworlds.com. Windows Shift S to grab a screenshot. Spectra show less than ideal alpha tuning with double frontal peak and excessive frontal alpha due to drowsiness. Pronounced frontal midline theta. Okay, and now let's take a look at the eyes closed data. I've removed all of the artifact rejection so that we can do it together here. And again, we see some EMG, this time actually more pronounced in the left midtemporal sight coming from the left jaw muscle. And some eye blink at the beginning of this, so we're going to assume that the person did not really close their eyes until about here. So I'm going to remove that from the spectral analysis. And what do we see? We see lots of alpha, as we would expect to see in the eyes closed condition, mixed in with some frontal theta, like we saw in the eyes open. So we'll scroll through, keeping an eye out for any interesting features. And it looks like we will need to remove a little bit of eyelid flutter using the ICA. And the eyes closed can be interesting in that sometimes we don't see a whole lot going on, and other times we see even more going on than the eyes open. Right now we're seeing some appearances of higher amplitude alpha that through volume conduction looks a little bit sharper at the front of the head. And alpha's doing what it likes to do, which is to wax and wane. Eyelid flutter, kind of eye blink, even though their eyes are closed. So this is not a profoundly sleepy EEG, in that we're still seeing predominantly sort of like an alpha state, alpha stage of sleep, and we're already 2 minutes in. Sometimes if people are super sleep deprived, we'll have already seen a full dropout, and even in a future episode, I'll show you an EEG where a person is already having vertex activity just a minute or two in. Is it eyelid flutter? Is it frontal theta? Just like in the eyes open, we're not totally sure. I'm inclined to think it's frontal theta. And theoretically, it's possible that that burst of frontal theta is also associated with a shift in vigilance that may prompt some eyelid flutter. I don't know. Right? This is where video EEG can be a little bit helpful, and or having an additional sensor or two on the face. Interesting kind of sharp looking activity here. That's phase inverted from left to right with a little bit of slowing at F8. alpha alpha everywhere with some interesting stuff happening at F8. Now, if we drag F7 down, we can try to look at phase and field to see if this is coming from lateral eye movement, and it looks like it's not. Right, if it was just purely lateral eye movement, they'd be doing the same thing, except completely phase inverted at the homologous site. And again, we're seeing this frontal slowing at around 5 hertz. 1, 2, 3, 4, 5. Scrolling through, little electrode pop here, or perhaps a muscle spindle. So it's kind of a sleepy EEG, but less sleepy than I thought in a way, and still somewhat rigid in terms of the predominance of alpha without a whole lot else, except for these occasional frontal theta bursts that pop in. Alpha is the idling rhythm of the brain, and we expect to see some at the back of the head with eye closure, and we expect to see it generalized as a person is experiencing drowsing. And too much alpha means the cortex is idling too much, which we see more often than not. Well, more often than one might expect, given how much increasing alpha has been popularized in the world of neurofeedback and kind of popular culture, right? Here we see a P7 alpha generator that's sort of acting a little bit more independently from everything else, although it is synced up with O2 and O1. And then frontal theta. Interestingly, we saw more bursts of frontal theta when the eyes were open, right? And frontal midline theta is a normal functional process. It can be a projection of the limbic system, right? A way for the anterior cingulate to couple with the frontal cortex, ideally cross frequency coupling with beta when there's a functional cognitive action to take place. And now we're seeing slowing that is more biased towards the temporal areas and also phase inverted from left to right. So it's a little different than what we were seeing in the eyes open. It's a great recording. There's really no channels that are an issue here. We can see that they're all sort of similar in amplitude. Not really any electrode pops, except for that one or two that we saw earlier. So this one's relatively straightforward to clean up. And we're really only looking to grab the EMG from the temporal sites and a little bit of the eyelid flutter, if we can. Just looking at our topographies here. Finding good topographies for the artifact we're trying to remove is a little bit of an art, and I'm not loving what this is giving me. So I'm going to switch over to the TON algorithm, which is a little bit more fine-grained in terms of what it picks out, and sometimes takes a little longer. This component has removed the EMG pretty effectively without squashing the cortical rhythmicity, so I'm happy about that. This looks like it might be some of that eyelid flutter that we saw pop up a couple of times. And indeed it is. So I'm satisfied with that component, and we may be done. Looks like we don't have a super solid topography for T7, and I'm okay with that. So I'm just going to scroll through very quickly to see if there's anything that needs to be manually removed. Looks like this might be one of the few instances where we do have T7 EMG. Not quite sure what that is, but that looks like a pop. A little more EMG. And this looks good. So we didn't see quite as many features of interest in this condition. So I'll probably only pick 3 fragments to screenshot. This is one of the rare instances of frontal slowing. And not exactly sure what it means per se. It's slowing is a natural phenomenon and also can be associated with transient ischemia or lack of blood flow, or like a brief metabolic disruption. This looks like some lateral eye movement that we didn't pull out, or perhaps cable sway, but more likely lateral eye movement. Here's some more slowing that's centered around F8. And another instance of this sort of front to back kind of transient slow wave. So let's pull this out. And that may be all we need for our little report that we're throwing together. Could remove that little fragment of lateral eye activity. And we can grab this and call this dropout followed by alpha realerting. Here's another instance of that sort of frontotemporal slowing. Mixed in with beta. And even parietal too. So why not? Let's grab this. Bilateral slowing mixed with beta. Let's call it that. And now let's take a look at the spectra. Fill by band range. As we expect, there's even sort of fewer features in the eyes closed since the alpha is so dominant. The alpha topography shows PZ kind of having the lowest amplitude, except for the central sites, which we don't love to see since excessive alpha in these areas in comparison to PZ can sometimes be associated with sensory processing issues. And we don't know that, but it's interesting nonetheless. I'm going to pick the peak from PZ, this highest peak here, which is at 9 hertz, which is on the slower side for an individual in their early 20s. And it is biased to the right occipital area in terms of highest amplitude. And then the question is, what else can we pick out here that's relevant, given that there isn't that much else that's standing out? We did see the frontal theta show up occasionally. I'm curious what this 16 hertz feature is and a little bit skeptical. We can map it, but I will return to the raw to try to get a little bit of insight into what's happening over there at FP1. Typically, muscle activity would not have that kurtotic or narrow of a peak in the spectra. So I'm inclined to believe that it's real, i.e. cortical, as opposed to a consistent muscle activity. And we do kind of see it at FP1. So that's interesting. There's possibly some frontal kind of tonic beta activity going on there. Although we're not sure about it. And we can take a peek at the coherence, and obviously this is going to be quite high in coherence because that's what we saw in the raw EEG. Interestingly, the 16 hertz activity is the opposite of coherent because it looks like it has a dipole that's going left to right in the front. which could mean that it is muscle activity just coming from one of the sides, which means it would be predisposed to be phase inverted FP2, even though we don't typically see muscle activity having this kurtotic of a peak. So I'm ambivalent as to the interpretation of that feature. And it's not impossible to see muscle tension with that distribution. And it's not impossible to see, cortical beta spindles in that area with this background presentation as far as everything else that's going on. So may or may not be significant. Let's go ahead and do a print preview. And I'm going to chop off the top of this part of the spectrum here so that we can see a little bit more of the distribution without having to squint so hard. And how do we describe this? Well, alpha on the slow side, hypercoherent alpha. May be associated with a lack of dynamic network activation. Peripheral alpha distribution may be associated with sensory processing challenges, although we don't know. And not a whole lot else going on, right? Which is part of the issue, right? We don't expect someone to have a ton of network activation in the eyes closed, but we also didn't see a ton of network activation in the eyes open. We kind of just saw a lot of alpha and some frontal theta and not very much beta. So now we come to the question of what's actually going on with this guy. We've summarized what we've found in the EEG. There's a lot of frontal midline theta in the eyes open. There's poor alpha blocking in the eyes open, so too much alpha up front. We saw some possible sharp transients in the eyes open. We saw lots of drowsiness in both conditions. And we also didn't see transition into deeper stages of sleep in eyes closed, which could be meaningful and could also not. We saw that bitemporal slowing, especially around F8 in the eyes closed, and we see a slow alpha peak, right? So that's what's happening in the EEG. And now our question is, what's going on with this guy? The first thing James communicated with me was a sense of physical anxiety. This person having difficulty sitting still. He's in his early 20s. And he wants to improve his focus. He wants to improve his sleep. He says he's never slept well. Like he has racing thoughts. And when he took Adderall to help with focus, it made him manic, as did Strattera. And it turns out he's vegetarian. And so this opens up an interesting question to me, right? How is it that this person who has some symptoms of anxiety and not being able to sleep well and difficulty focusing, how is it that that matches with having all of this alpha, right? I want to do a video on ChatGPT and how ChatGPT gets certain things wrong about EEG, but when you look up alpha on the interwebs, they say it's associated with relaxation. And that's only part of the story because it's also on a physiological level associated with idling, i.e., kind of a resting state of the cortex. And I remember Dave Seaver talking about this early on in my own sort of EEG and neurofeedback journey of seeing people with this kind of a presentation where there might be too much alpha and or theta up front, where they present as being very anxious, right? And the first thing we might think of as far as EEG correlates of that overarousal might be too much beta, too much fast wave activity. And this is what's interesting to me and always surprising about looking at the EEG is that we have these concepts in our heads about what someone's brainwaves are going to look like based on what they're presenting as outwardly. And yet the brain tells a more complex and nuanced story. And so, is this the EEG we're expecting? Yes and no. Right? In relation to the difficulties with attention, focus impairment, let's say, I think there's a good chance that frontal theta and alpha could be related to difficulty paying attention, maintaining focus. I think also the low alpha peak, right? The 9 hertz alpha peak, we could tune that up a little bit to help with a sense of mental clarity and energization. And I think also just the lack of beta activity in the eyes open is a sign that there is a low baseline level of wakefulness or vigilance. And it can be hard for us to tease that apart from, focus and attention, right? These things are very much overlapping Venn diagrams with each other. And then there's the question of poor sleep quality, right? So we didn't note any sensory motor rhythm activity in either of the recordings. We don't necessarily expect to see a whole lot of it, even in the spectra, right? So if we go over to the spectra, we can maybe see a little bit of a bump above the typical alpha range, but it's hard to say. We didn't necessarily note it in, in the raw, right? And, to be honest, I don't see it that often because it's an intermittent feature, right? We wouldn't expect to see it in any, 20-minute little snapshot into someone's brain. And yeah, a medical sleep study could help rule out what's actually going on there. Right, we did see some possible sharp transients in the eyes open. So I would wonder, how often are those happening as this person's trying to fall asleep? Right, is that preventing them from going into the deeper stages of sleep? There could also be a lot of rumination happening right before bedtime, where it's hard to fall asleep just because that frontal theta feature, that sort of anterior cingulate being stuck on a particular subject and churning it over, makes it difficult to actually fall into deeper stages of sleep. And then I'm also curious, and this is really outside of the domain of the EEG assessment, but looking at the steroid hormones, right? Cortisol, testosterone, progesterone, estrogen, melatonin, specialty testing. You can do urine organic acids, that you can do the Dutch complete. Right, just looking at basically the graph of cortisol over the course of the day, because this presents as someone who's slightly under aroused all of the time, right, with the slow alpha and the lack of beta. And so I'm just wondering if there's actually just a suppression of that cortisol graph, that cortisol curve over the course of the day. A lot of people don't know this, but having chronically low cortisol can actually present outwardly as having a kind of anxiety physiologically. and contribute to, racing thoughts potentially, and poor sleep quality too, right? If there's like not a lot of amplitude to these different steroid hormones, it can be hard to get that, pulse in the morning and then get that kind of trough in the evening. So that's sort of my interpretation here, my attempt at kind of making sense at a case that on some level makes sense, and on another level I'm wanting more information about. And I would love to hear some suggestions and also some follow up about how this is going and what some of the further testing shows. And I'm going to give some recommendations, right? And again, I'm not the clinician here. This is just like what comes to mind from my own experience as to what could potentially be useful. And it's up to James to figure out what he's going to try out and what's within his comfort zone and sort of zone of familiarity. And I think there's a lot of potential avenues here, right? So I think, red light therapy, transcranial photobiomodulation could be really helpful. If there's an issue in going into those deeper stages of sleep, right? It takes the brain actually a lot of energy to do that. When you look at the large slow wave activity, it takes a lot of like electricity, i.e., mitochondrial output, in order to create that deep sleep. And there could be a bunch of different sort of biochemical reasons and neurophysiological reasons why that's not happening. But red light therapy seems to help with that. And you start out 5-10 minutes a day, you feel more tired afterwards, you sleep better that night, and you do that for enough days in a row, and that starts to make a real shift in terms of daytime wakefulness. Neurofeedback, right? Classic protocol that I think this is a real good candidate for is inhibiting that slow activity in the front of the head. So you set inhibit from 4 to 12 hertz, and then you can reward the low beta if you want to, and this 15 to 20 is really just a suggestion, or you can just inhibit the slow and see what happens, right? Turning on that salience network. We can do classic SMR neurofeedback, right? If there's problems falling asleep, we might as well see if this starts to make an improvement. Right now, it seems like the thalamus is basically just putting out alpha, and maybe that's part of the problem. Maybe it's not putting out enough SMR and sleep spindles, the sleep correlate of SMR, while he's trying to sleep. I'm also going to recommend audiovisual entrainment, right? The David Delight device. I mentioned Dave Seaver earlier, but I think it's a great tool for helping people improve their sleep quality. And I would be very curious how this guy responds after even a single session of that. I bet you he's going to take a nap, and then when he goes home, he's going to have the best night of sleep of his life that night. And that's a pretty straightforward thing to put on and do. So that's even something that people take home with themselves and just, do it in the evening on their own. Some stimulation protocols that I'm recommending. You could do the alternating current square wave, AFC to PZ, right? So one electrode at the front of the head, one at the sort of posterior cingulate. And this is at 0.1 hertz, the infraslow oscillation of anterior cingulate, posterior cingulate activation. And I say that may entrain a more balanced anti-correlation of the currently hyperactive default mode network with the hypoactive salience network. Anti-correlation just means that they're supposed to be turning on at not the same time. Pink noise and or low beta stim at F7, F8, right? The front side of the head is not really turning on. You could see if that helps to gently get things more activated, get more blood flow up there, get more low beta activity. And then I talk about medication a little bit, and I will remind you that no medical advice is given. This is a YouTube entertainment product, so don't come at me for talking about medications here. Um, I'm not a doctor. And on some level, the Adderall wasn't the worst choice, even though I'm guessing the psychiatrist did not look at the EEG, because there's a slow alpha in the eyes closed, at least. In the eyes open is why we're not surprised that the Adderall maybe wasn't super comfortable, because there's already a faster peak of alpha. There's already some difficulty in tuning that alpha peak at the front of the head to where it wants to be at the back of the head. So maybe the Adderall, which tends to speed up the background rhythm, was uncomfortable because there's already this faster alpha feature up front. I don't know. Just guessing. Um, but right, if there's difficulty with wakefulness regulation, which it seems like there is, modafinil um, may be more effective. So that's something for them to talk to their psychiatrist with, right? And as far as the frontal theta is concerned, uh, methylphenidate or Ritalin, which is a reuptake inhibitor. So it's also less edgy than something like alpha is, which is a dopamine agonist. Methylphenidate will help reduce that frontal theta, and it's a reuptake inhibitor both for dopamine, norepinephrine, and to a lesser extent, serotonin. It's a little bit more of a balanced effect than Adderall, at least in my experience. Adderall is a little more edgy. So again, these are things for them to talk with their doctor with. And I'm not giving any medical advice. I have no clinical licensure in any U.S. states. And this is just my approach. It's not the approach. I'm just a student, and I'm sharing this because I find it interesting. And I am also curious to hear what you all have to say. If you have any comments, any questions, any follow-up from James in the future, we can potentially do a follow-up video as well if there's a remap in the future after some training has happened. If you watched this far, thank you so much for watching. I hope this was fun. This is my little EEG analysis process, and it's fun for me to do, and I'm eager to hear what it is that you found useful, what you would like different, what you would like more of. And again, if you would like your own QEEG interpretation, you can head on over to traceneuro.co. And I look forward to seeing you on the next one. Thanks for watching.